So good morning, everybody. This is always a very special day. This is our named lectureship for our beloved Dr. Mona Shimshi. Dr. Shimshi did her fellowship training at Mount Sinai and spent the better part of her career in some sort of affiliation, either full-time faculty or an affiliated faculty at our healthcare system. During her fellowship, she did research in metabolism and lipids and metabolism with Dr. Virgil Brown with that group, and she maintained a lifelong interest in the field of lipidology. But she was probably best remembered by all of us, including her many, many trainees, as a beloved teacher and mentor. She was our fellowship director, and I'm now the fellowship director, and I can't quite live up to her standard because she was more than just a fellowship director. She was a mother hen to her fellows. She really took care of them in every which way. We lost her too soon, and this lectureship was developed in her honor. Initially, our speakers were mainly in the field of lipidology, but then when Dr. Deaconess took the helm of our division, she had what I think was a great idea to make it more about Mona's legacy as a teacher and a mentor. And so for the past several years, the speaker that is chosen for this honor is chosen by our fellows, and they come up with a list and they decide who it is that they want to sit in this chair for this hour. And so one of our fellows, Dr. Lena Shah, who is one of our rising seniors, is going to do the formal introduction. And I just want to thank Dr. Maratos-Flier for agreeing to be our speaker this year. Thank you. Lena, take it away.
Hi, everyone. Good morning. My name is Lena. I'm a first-year endocrine fellow, and I'm honored today to introduce our guest speaker for the Mona Shimshi Lecture and the recipient of the 2020 Endocrine Society Roy O. Greep Award for Outstanding Research Contributions, Dr. Terry Maratos-Flier. So Dr. Maratos-Flier completed her medical training at our very own Icahn School of Medicine and is the winner of the 2012 Mount Sinai Saul Horowitz Distinguished Alumni Award. Currently, she serves as the Director of Translational Medicine at the Novartis Institute of Biomedical Research, and she is Professor of Medicine Emerita at Harvard Medical School, affiliated with Beth Israel Deaconess Medical Center. Dr. Maratos-Flier started her research career in 1981 with a research fellowship at the Joslin Diabetes Center. Her current major research focus has been defining mechanisms that regulate energy homeostasis using mouse models. Her lab discovered the orexigenic action of the neuropeptide melanin concentrating hormone. She became interested in the effect of macronutrients in both physiology and gene expression. Studies of ketogenic diets in mice led to the discovery that fibroblast growth factor 21 was substantially regulated by ketosis in mice. This led to work where her lab defined the role of FGF21 in regulating hepatic pathophysiology, as well as the physiologic actions of FGF21 in regulating brown adipose tissue and browning. In the past several years, Dr. Maratos-Flier has been interested in understanding human fibroblast growth factor 21 physiology and the relationship between the FGF21 response to fructose and diet composition, metabolic syndrome, and obesity. Her group was the first to define fructose and alcohol ingestion as potent inducers of circulating FGF21 in humans. Her research is of particular interest to me as the increased use of high fructose corn syrup and its potential role in the metabolic syndrome were initially what inspired me to investigate the effects of high fructose diet on neuronal aging in the C. elegans model in college. It was this research experience that directly led me to a career in endocrinology. In that regard, while I've not had the opportunity to work directly with Dr. Maratos-Flier, I have learned a great deal from her research, and she has become a mentor from afar to many young trainees, such as myself, through her contributions. And so I, along with the other endocrine fellows, am delighted to welcome Dr. Maratos-Flier here today as she shares with us her expertise in obesity and human FGF21 physiology.
Wow, thanks so much for that wonderful introduction, and thanks so much for inviting me to all the fellows. I really am honored to be giving this lecture, and it's kind of like the only thing would be better if I could give it live at Mount Sinai, but we're doing what we can in the current era, but thank you. Okay, so if I now can get to my share screen without too much trouble here, let's get started. Okay. So can you all see my screen?
Yes, yeah, that's perfect.
And it looks fine? Okay.
Yeah, go ahead.
One slight adjustment here if I can do it so I can see it a little better. Okay, so I'm going to talk about targeting human obesity. As Lena said, I'm at Novartis Institutes for Biomedical Research. I don't have any conflicts of interest because I'm not talking about any drugs or products that Novartis has. I will say that Novartis was working on an FGF21 extended half-life agonist, which was now licensed to Boston Pharmaceuticals, and there's going to be a nice paper coming out about that. I actually did not work on it other than as a consultant within the company, but I can't tell you about that because it's not published. So yeah, I would love to be able to add to the human FGF21 story with that data, but at the moment it's not an option. So maybe sometime. Okay, so now how do I advance my slides? Hold on, now I have to go to my other screen. Sorry about that. Where is my arrow? There we go. Okay, that should work. Okay, so I'm going to start with a definition and scope of the problem of obesity. I'm going to review complications and treatments, and then I'm going to give you a short overview of FGF21 as an example of the challenges in developing new treatments and also defining new physiology, because FGF21 was originally discovered at Lilly about 20 years ago, and we still don't fully understand the physiology. So I think it's a really good example of all the challenges. So since I don't know everybody who's here, and I don't know if there are any students here, I am going to briefly talk about body mass index, which is the weight in kilos over the height in meters squared. To give two very cartoonish examples, a woman who is 5'4", weighs 180 pounds, has a BMI of 30. A person who is 64 inches tall, weighs 125 pounds, has a BMI of 21. So it's a really crude index of the ratio of weight to height. Now, this definition has taken a beating. If you follow anything in like the newspapers, in magazines, et cetera, everybody says, oh, we shouldn't use BMI, we shouldn't use BMI. It's a terrible indication of body weight. So why do we use it? Why do endocrinologists still use it? So the pros of body mass index is it's very easy to measure height and weight in an office setting. People say, kind of substitute a waist to hip ratio. If anyone's tried to do a waist to hip ratio, particularly in somebody who has central obesity, even defining their waist can be a problem. So it's not like there's an other easy measurement. And then other people say, well, why don't you have scales that measure impedance and measure it that way? Well, not everybody has that scale. It's really easy to self-report. So if you're doing a study for the physiologic studies that I did when I was at Beth Israel Deaconess, one of the cutoffs is what's your BMI. So like getting a height and weight from a person is very, very easy. it's really good for assessing obesity in a population. So it's been excellent for epidemiologic studies, which makes it good for comparing population. And it provides an index of risk for comorbidities of obesity. So the cons of BMI are it's only an index. It is not a diagnosis. It's not like your BMI is 32 and you are obese. You have to take into account other variables. You need to, when you're looking at BMI, you need to evaluate the BMI thresholds for different populations. So the concept of excess adiposity is not the same if you're looking at somebody who is of European ancestry versus somebody who is of Asian ancestry. It contradicts the popular narrative of health at any size, which is a narrative when I come across it drives me completely crazy, because you can be healthy with excess adiposity, but you need to know what else is going on. And then the other issue with health at any size is that how long will you be healthy? So I have some individuals who I see for their body weight who are in their 30s and actually have no comorbidity, but will they maintain a BMI of over 40 into their 50s without a comorbidity? And there are some healthy high BMI individuals. So I think, it's kind of gotten a bad rep because it's people aren't really looking at it from the perspective of any subtlety. So this is just to show you what those famous BMI curves look like. And if you look at this, up until a BMI of, can you see my arrow? I didn't do the laser arrow, so I don't know if you can.
Yes,
can see.
yeah.
Okay, so it really, the increase in risk is very, very small up until you get to about 30. And if you look even in this range of 30 to 31, yes, there's increased risk, which means only some people are going to have that increased risk. And what you need to be doing when you're looking at the increased risk is you should be looking at other factors like family history and lifestyle. And as I said, for how long will people be healthy, because there is increased risk with increasing age. And you have to remember it's not a diagnosis and the alternatives are more complicated and maybe less reliable. So this is just to show that the new BMI criteria in European are different in Europeans and Asians. And it's noteworthy that if you look at these criteria, obesity is defined as a BMI of greater than 27.5 in Asians, whereas it's defined as a BMI of greater than 30 in European individuals. These have now, and so on. The other thing is we used to call extreme obesity morbid obesity. I don't know, we don't do that anymore. It's now class 1, class 2, and class 3 obesity. You can also use the term polysarchia if you want. And again, these are different in Asians, and these are the WHO have been adopted by the WHO, which is the World Health Organization, and have also been adopted by the health authorities in China and in Japan. I don't know if they've been adopted by health authorities in South Asia. I wasn't able to track that down, but the very same increased risk at relatively lower BMIs exists in South Asia. So in India, Pakistan, Malaysia, etc. Okay. So this is the, just to show you, everybody's seen the obesity, I'm sure, maps in the United States. And I wanted to show that this is the obesity map in 2020, and this is the predicted obesity map in 2030. And this is now class 3 obesity. This didn't get mapped. Five or 10 years ago, we didn't map class 3 obesity. So these are individuals that have a BMI of over 40, and they're now close to 9 million individuals right now. And that category may be increasing. And then this is again to show that from the perspective of BMI, this is also part of the difficulty in interpreting data. These are Europeans, these are Black individuals, and these are Asians. But remember, this is based on that cutoff of 30, okay? So we have to actually probably go back and redefine this particular category, okay? Now, one of the biggest problems with obesity is that almost 46% of individuals that have type 2 diabetes 42 are obese, okay? And this is at the actual breakdown. Only 11% are normal weight, 27% are overweight, 45% are obese, and 15% are actually morbidly, God, I'm still using it. Tells you how bad it is to change your habits, have class 3 obesity. And the total number of obese individuals in the United States is, of diabetic individuals in the United States is 34.1 million, with about 27 million that are diagnosed. There's about 7 million that are undiagnosed. And these are kind of the ethnic racial breakdown in terms of the proportion who are in these categories. Proportionately, individuals with Hispanic backgrounds and with who are Black, non-Hispanic are more represented. Asians, because even with the new BMI definitions, are actually underrepresented because they are relatively lean. And this is the world population map. I don't know if anyone has seen this. This is from I think it's either the IDF, International Diabetes Foundation. Yeah, it is the IDF here, which is the prevalence of diabetes. US used to be #1, and I'm old enough to remember our European colleagues making fun of us, okay? Because we were like the leaders in becoming the most obese population in the United States. And right now there are many countries that are actually catching up with us, and in particular in Saudi Arabia and in the Middle East, countries are catching up. And then you can see that actually diabetes is more of a problem in Mexico and again in the Middle East. Okay, 463 million people with diabetes throughout the world. Okay, this is not obesity. And as a result of obesity, these maps pretty much overlap. The map on the left showing you the obesity and kind of mapping with the diabetes. These are some of the breakdowns. This is a new trend of childhood obesity, which is very disturbing, because the heavier you are as a child and as an adolescent, the more likely you are to increase that weight and go into the obese category as you get older. You can see that the problem is, almost 14% of this is white, this is Black, this is Asian, and this is Hispanic kids as a total are obese. And in childhood, it's actually the Hispanic population which is more obese than the rest, other children. Okay, this is like the racial background numbers. So if you look here, African Americans are the most likely to be obese as a general population. Now, interestingly, it turns out that among men, these numbers are not actually statistically different. So people of European descent versus African descent in the United States, if you're a male, the rates of obesity are actually pretty similar, and much lower for people of Asian background. But among women, there is a very significant difference in obesity between European, African, Asian, and Hispanic. So these numbers here are actually more driven by the female population than by the male population, the totals, because the men, in fact, aren't all that different as compared to women. Obesity is definitely more of an issue in individuals who are poorer and who are less educated. So you can see here, if you look at high school, some college, and then college graduates, women who are college graduates are less likely to be even overweight than women who have less education. So this is a substantial difference. And less of a substantial difference in men. So you can question what the cultural issues here that educated women are more likely to be conscious of body weight than educated men. So this is not as big a gap. And this gap, okay, it is also seen if you look at different races and ethnicities. More education and more wealth, better socioeconomic status is associated with less obesity. So the economic costs in the United States are estimated between 150 to 190 billion, with a 50 billion increase in the next decade. The increase in health spending per individuals depends on what study you're looking at. So this is like an average is between $1,400 and almost $3,000 a year. If you've developed a comorbidity, it is substantially more. So if you have a comorbidity, it's $9,000 to $17,000 a year if there's a comorbidity. Even without a comorbidity, there is an increased absenteeism for illness. People are more likely to get sick. We've seen that in terrible outline, terrible clarity with the COVID epidemic, where BMI really acts as a major factor in increasing risk for morbidity and mortality if somebody gets sick with COVID. And then there's a thing called presenteeism, where business people and epidemiologists calculate like productivity at work, and there is an association with less productivity in individuals that are more obese. Okay, everybody talks about this as the modern problem. This is not a modern problem. If anyone knows this cast of characters, these guys are from the Tudor era. You can see Henry VIII at age 20 over here on the upper left. He was considered to be one of the most attractive monarchs in Europe. I mean, he would have gotten like one of the sexiest man alive from People magazine if People magazine existed in the 16th century. And he died at age 58, probably of some infection related to his diabetes. He weighed close to 300 pounds. He had incurable ulcers. He had gout. He had every comorbidity you can think of. Of course, they didn't define diabetes in that era, so we can't say that he had it, but sort of medical historians feel that his primary problem was he had type 2 diabetes as a result of his obesity. These are two guys that are not too slim either. They're two of his counselors. These guys are in their 50s. He decapitated both of them. He sentenced them to death. This is actually the Maximilian I, who was the leader of Austria at the time. Thomas More, Thomas Cromwell, and Maximilian. If you look at the menus that these guys had in that era, the lesson point here, or the learning point here, is they had what is the equivalent of free access to food. They didn't hunt it, they didn't cook it, they didn't bake it. It was presented to them. And the cheaper food is, from the perspective of both economic cost and manual cost, the more likely you are to get obese. So for example, in Nigeria, which is kind of becoming a wealthier country over time, if you look at the obesity, it is in the wealthy population in the cities. It reverses that demographic that we see in the United States. And these guys are a good example, more than 500 years ago, and they're developing their obesity. So what's the pathophysiology of obesity? Well, it's a really great example of genes interacting with the environment. So there are a few monogenic obesities that I will touch on, which is single gene defect. If you have this gene, you are as likely to be obese as if you have a mutation in the chloride transporter. You're likely to have cystic fibrosis. And then we have polygenic obesity. Most individuals who you see in clinic will have multiple genes that contribute to excess body weight. There's something like 200 that come up in GWAS studies, genome-wide association studies, that increase susceptibility. But this cannot happen unless you have diet availability. So whereas the genes of the population hasn't changed in the last 100 years, the cost of food has actually changed dramatically. And also the type of food that we're eating. So we're eating like less nutritious food, it's less expensive, and it's just easier to get. I'm sure you can go to your cafeteria and buy a donut. One could question the wisdom of selling donuts in hospital cafeterias. I was part of an effort at Beth Israel Deaconess to stop selling or to decrease selling sugared sodas. And the result of that effort is instead of having 6 sugared sodas at the soda fountain, I think we went down to 2, and then the rest were Diet Coke, but they couldn't eliminate them all, even though we're in a hospital. And then the other issue is physical activity. We are much less active in the Western world now than we were 100 years ago. There are fewer jobs that actually require a lot of manual labor. So a lot of things have been mechanized. A lot of, think about farming, it's all big machines and the trades, even though people are more physically active if you're an electrician than if you are a researcher sitting at your desk writing manuscripts, there's just less of employment that it requires a lot of physical activity. So this would be a non-controversial statement now that body weight is regulated and obesity has genetic components. It was a very controversial statement even I would say 30 years ago. It took a while. The data that body weight is regulated came originally from mouse models, and some of it was very general kind of mouse models. If you take a C57 black 6 mouse and you put on a high fat, high sugar diet, they gain weight beautifully. They actually gain about 1 gram a week. If you take a different strain of mouse, the 129 mouse, and you give it the exact same diet, they don't gain weight. And it's not because they're virtuous, okay? It's not that they're not eating that yummy high fat diet. It's that they actually have increased energy expenditure and manage to regulate their energy expenditure so that they increase it when they're on a high fat diet so that they're resistant to diet-induced obesity. The other thing that it took a while to recognize that weight is at least as hereditary as height. So if you look at your family, you may have a pretty good idea of what your weight is going to be as you're growing up and as you're growing older. And then the other thing that we got from mice is the single gene mutations that are associated with morbid obesity in both mice and humans. And those findings actually are at this point about 25 years old. Now, amazingly, this is from the Daily Mail. There are physicians and there are people who say if you're obese, it's because you eat too much. I mean, it's kind of amazing that you can entirely blame individuals and say it's, you're just eating too much, and medical treatment is not the right thing to do. And I encounter this, that, if that person would stop eating, they would just be fine. The worst case scenario is when I encounter a patient that I've kind of pushed slowly over many years to bariatric surgery, and then they'll see a cardiologist or they'll see another specialist, and that specialist will talk them out of it. So one thing I also wanted to point out, that the tendency, this genetic tendency for obesity, probably has a survival benefit. So each pound of fat provides calories for 2 or 3 days. So an extra 55 pounds could increase your survival for about 5 months. There's a famous case of these people who crashed a plane in the Arctic and survived for about 3 or 4 months, kind of melting ice and drinking it. They didn't have any food. They were both overweight to start with. They were significantly overweight to start with. And in fact, if they had been normal weight, they would not have had that survival, because they would have not had adiposity to draw on. Everybody probably knows this picture. This is the famous OB mouse. This mouse came to us via a spontaneous mutation in 1948 in the Jackson labs, where it was clear from the genetics that it was you needed to be homozygous for the OB gene. It was studied for many, many, many years. And then in 1995, Jeff Friedman described the missing gene as the OB gene. He called it leptin, and life without leptin, whether you're a mouse or a human, is actually very difficult. This is the image from one of my colleagues in Cambridge who was actually studying familial obesity, and this child presented at the age of 2.5 years. He weighed about 80 pounds. He was constantly crying if he was not given food. I'm good friends with the PI who treated this kid, and she said, like, the parents were desperate. They had to put some kind of like porridge in front of him continuously, otherwise he would be desperate and crying. And this is 3 years later, he received leptin as a treatment, and he is now in the normal BMI range for his age, height, and weight. And the effects are really, really dramatic. Sadat Faruqi also followed one of his cousins. Now, if you are a leptin deficient person, you cannot go through puberty. You will be class 3 or more obesity for life. And it will be a very tough life. His cousin, who is a girl, when she started getting leptin, actually went through puberty and got married and now has kids. And my friend feels that this is like one of her great clinical successes. Okay, leptin deficiency is very, very, very rare. You almost never seen it. It's an unusual genetic defect that is probably somehow selected against, which I've never fully understood. But because that would suggest that even the heterozygote provides no survival advantage. The more common single gene defects explain some human obesity, and the most common gene defect is actually a defect in the melanocortin 4 receptor. So this is a complicated system. I decided not to go into the details because it takes a long time to do it. But the MC4 receptor is expressed in the brain. It is targeted by an agonist and an antagonist. And without a good functional MC4 receptor, those individuals will be prone to obesity. The obesity is not as dramatic as a leptin deficient individual. And if you're looking at in a pediatric clinic, about 5 to 7% of early onset of individuals will have a mutation in the MC4 receptor. And this is actually a genetic test you can do. Athena Diagnostics will actually test for MC4 receptor mutations. The mechanism is that alpha MSH inhibits appetite. It's made in the hypothalamus, and without the MC4 receptor, you cannot get that signal to inhibit your appetite. The other more common mutations, there are actually more individuals with leptin receptor mutations than there are leptin gene mutations. POMC gene mutations are really interesting because with the abnormal transcription of the POMC gene, those individuals have red hair. And that's because in the periphery, the melanocortin 1 receptor regulates coloration of skin and hair, and they will also have adrenal insufficiency and usually present in childhood with adrenal crisis. And then there are these proconvertase gene mutations. I think there are a few individuals that are described with those. There are certain syndromes where the obesity is not fully understood. Prader-Willi is one. It may have something to do with ghrelin. I've never been totally convinced with that data, but there is some indication that the individuals with Prader-Willi have abnormal secretion, excessive secretion of the hormone ghrelin from their stomach, but they are very, very commonly obese, as well as also having other issues related to some cognitive defects and the way that they feel pain and nausea. So common obesity is probably due to small changes in multiple genes. Complete loss of function will lead to morbid obesity. Multiple small hits in terms of loss of function could also just as well be gain of function, could contribute to obesity. There was a huge amount of money spent doing genome-wide association studies to try and define these genes. One of the ones that came up from the GWAS studies was FTO. It describes a SNP that was seen in, the signal came out of 38,000 subjects. It codes for a gene 2-oxoglutarate dependent nucleic acid demethylase. And the last I checked, there's still a debate of exactly what it's doing to predispose to obesity. Is it epigenetic modification in genes in the central nervous system? There's a lot of debate about that, but that may actually be the mechanism. And when you think about it, the effect is pretty small, 1.5 to 3 kilograms. So this is like one of the issue of trying to sort through the forest of GWAS studies to find the tree that might actually lead to obesity. You know, not much was discovered, and you know, it's kind of disappointing from both a scientific point of view and the research point of view. And we can ask the question is, why haven't there been more insights into the obesity pathophysiology? So one thing to think about when you're thinking about obesity is that even in the most obesogenic environments on Earth, which I could say is probably Western cultures, 30% of the population does remain lean. And they're not just lean, but I call them mindlessly lean, not to be, you know, hopefully too jealous of people who can eat what they want and remain lean. My father was actually one of them. He weighed 147 pounds his entire life until he got so old that he started to get the sarcopenia of the elderly. And my father never dieted a day in his life. And my mother was a really good cook, and he got free access to food. I mean, he worked, but my mother bought the food, prepared the food, put the feta cheese, the Italian bread, the baklava, the pasta in front of him. He ate whatever he wanted, and he never thought about it. And my mother would watch him and say, if we had to put this man on a diet, it would be a real problem. Maybe the disease is leanness. Maybe it's only in the context of the environment that the disease actually becomes obese. Because if you think about it, if you're lean and you get crash land in Alaska and you're there for 3 months, you need that excess fat. So if you were going to be in a famine, if you had a irregular supply of food, the excess weight would be a good thing. So what we're looking at in terms of like these are quintiles of obesity. When we look, you know, when the GWAS studies look, it's like starting here. Okay, maybe we should be here. Maybe we should be looking in the underweight population to see what genes actually keep individuals in this kind of the low normal weight. And would we actually be finding genes if we were looking there? There are now some studies that are starting to try and do that, to look to see if there are signals that can be identified that will keep individuals at like a BMI, healthy individuals between a BMI of 19 and 21. Maybe that's where we will get some information. So if you look at the flow of obesity in a population, most of the population is here with a BMI between 19 and 25. There are actually healthy individuals at BMIs below 19, but here you have to worry about other underlying illnesses that might be contributing. And then this kind of normal weight BMI, especially with aging and increased food in the environment, starts to drift to the BMI, the overweight BMI. And again, I'm using the European standards for BMI here, 25 to 35. Some of these individuals then shift to a BMI of over 30, and then some of them will shift to a BMI of over 40. And I think this shift is determined by polygenic gene scores. I think, you know, whether or not an individual can get to a BMI of over 40 is going to have a lot of factors associated with it. And some of them are going to be the underlying genetic predisposition that you can get to a BMI of over 40. And even here, where you are, whether you have, you know, a BMI of 30 or whether you have a BMI of 36, that may also be very dependent on genetic breaks that you either have or don't have to increasing your BMI. So I think here, this is likely to be very genetic. And I think here, this is also likely to be very genetic, but we haven't been good at picking up those signals. I'm going to say a little bit about the environment, activity versus exercise. Necessary manual labor is great at keeping people lean. Exercise is inadequate for weight loss. This is kind of like discretionary exercise. And one of the reasons is inadequate for weight loss is a combination of psychology. A 150-pound person walking at 3 miles per hour for 30 minutes will use 118 calories. And then they may go and have, like a really nice snack that's 120 calories. There's also a lot of evidence that weight loss that's secondary to energy expenditure, people compensate really well by increasing their appetite. In terms of the environment, diet, increased availability at decreased cost. Changes in dietary advice, like the eat more carbs was probably really bad advice that was promulgated by both the American Diabetes Association and the American Heart Association starting in 1970 until a few years ago. And there is data that eating more carbs actually is associated with an additional predisposition in weight gain and just kind of general ignorance. And I just wanted to show that this is the 1,337 calorie McDonald's meal if you order it as a supersizing. McDonald's has become much more health conscious. You can now get a salad that's decent at McDonald's. And this is like eating patterns in the United States. The potato defined as a vegetable, which it should not be, 120 pounds per person consumption. And this is 2011 data of potatoes, and it's approximately 5 pounds per year of broccoli per person. So you can see that our data isn't really great. Everybody, and mostly insurers, health plans say diet and exercise. So if you can have an individual's reduce their net calorie intake by 300 calories a day, they will lose 2 to 3 pounds a month. This is really hard to do because of all the counter-regulatory stuff that kicks in pretty much around the time you've lost those 3 pounds, and then it makes it a lot harder to lose additional weight. So when we get to treating obesity, this is actually the recommendations for pharmacotherapy versus surgery. You can consider a drug if the individual has a BMI of over 27, and you can get insurance to pay for it, and they have risk factors, and they have a trajectory of weight gain. Above a BMI of 30, you should strongly consider risk factors and try and encourage people that once their diet has failed, which most likely it will, that they should in fact consider a medication. In the category of 35 to 39, definitely a yes for thinking about a medication. And at this point, we start thinking about bariatric surgery. And over 40, a BMI of over 40, absolutely you should be treating those individuals and trying to encourage them to go to bariatric surgery if the drugs are failing. So these are I'm not going to do the trade names. I wrote them here so everybody would know that you might not hear about them as phentermine and the various generic names. These are the agents that are available in terms of approved to treat obesity. Among these, you can see that it's pretty modest weight gain. For people who respond to Contrave, they can actually get really fantastic weight loss. But only a small number of people will respond to any of these therapies. And the best one in this group approved for the treatment of diabetes is actually liraglutide, which Novo Nordisk markets as Saxenda, which will lead to pretty sustained average weight loss of 8 kilograms. But in any given individual, that could be a lot more than that. Now I can talk about the miracle of Ozempic, which is one of the GLP-1 receptor agonists, which combined with intensive behavioral therapy leads to profound weight loss. This was just published in, I think, January of this year. And if you look at, this is the placebo, which involved intense behavioral therapy. And this is treatment with Saxenda. So substantial weight loss at 68 weeks, and individuals will sustain this as long as they stay on semaglutide, also known as Ozempic. And these are like the number of people that had the percent weight loss with semaglutide versus placebo. And you can see, more than 10% weight loss was seen in 74% of individuals that were getting Saxenda. Okay, brief history of GLP-1 agonists. This is a fantastic story. GLP-1 is made in the L cells of the distal ileum and colon. It leads to, it's product of the pro-glucagon gene. Levels rise in response to nutrient intake. It has a very short half-life. It induces insulin release that's glucose dependent, so it will not make you hypoglycemic, and the initial efforts to engineer longer half-life of the peptide failed. A physician, Eng, was messing around with looking at the skin of the Gila monster to see if he could find hormonally active compounds, and he found one. And it was Exendin, which has some homology to GLP-1, does a great job activating the GLP-1 receptor in the brain. The first drug in this class was exenatide, which is derived from the Gila monster, marketed as Byetta for type 2 diabetes. And then incidental weight loss was noted in these patients. And then the weight loss was noted in obese individuals without diabetes, and the drug development for diabetes, which is now also kind of moving over to obesity, is Victoza, which is liraglutide, dulaglutide, and Ozempic. And it's kind of what I would call serendipity in action. Nobody would have ever expected this. So GLP-1 receptor agonists probably mediate weight loss in my mind, I guess, view, by moving the satiety threshold over. So if you're sated with, an 800 calorie lunch, if you're not taking your GLP-1 receptor agonist, the amount of calories you need to ingest to be sated is lower. And when I've talked to patients that I've prescribed it, that's kind of what they're prescribing. Surgery does the same thing. The thing about surgery is it actually induces higher levels of GLP-1 in the circulation, and it can lead to 60 to 80% excess weight loss. That's very sustained out to 20 years. Walter Pori showed it, other people have showed it, as well as reversal of the comorbidities. And I'm going to flip through these really quickly to show you that not only do you get these amazing weight loss that's sustained, this is out to 15 years. People who have the surgery are much less likely to become diabetic. This is without surgery, this is with surgery. And you can actually get reversal of type 2 diabetes. This is the surgical slide showing that the percent without diabetes after surgery over time, and even at 15 years, there is a significant reduction in type 2 diabetes after surgery. So obesity is not just excess weight gain. You've heard all of this, all the bad stuff that happens if you have obesity, ranging from cardiovascular disease to cancer, especially liver cancer, liver disease, infertility, osteoarthritis, cognitive decline. And this is like the relative increases of these as you progress from obesity to diabesity to having now type 2 diabetes as one of your comorbidities. So it's something that needs to get treated. So can we discover new treatments? So one of the things that I did in my group was ask the question, does diet regulate metabolism? And you could do this with gene expression. It might change gene expression. It might change epigenetics. It might change the microbiome. We focused on gene expression. I'm a microbiome pessimist. So I was interested in gene expression. And we did a diet where we put mice on conventional diet, a high fat, high sugar diet, a ketogenic diet, and then we calorie restricted them. And this is what happens. So this is mice eating the high fat, high sugar diet. This is chow. And this is the ketogenic diet. Okay. And this is calorie restriction aimed at matching the ketogenic diet. And what's really interesting is the total number of calories consumed is actually the same and the three diets that are provided ad lib. And what happens is that the mice that are eating the ketogenic diet have increased oxygen consumption. And that's why they lose weight. This is looking at oxygen consumption per kilogram per hour, whereas the other mice all kind of have this very similar oxygen consumption. Okay. And what we did is this was around 2005. We looked at gene expression in the liver, and we found this huge induction of FGF21 in the liver. And at the time, there was like 2 papers published on FGF21. So we had no idea literally what we had here. We confirmed this with a lot of experiments where we looked at not by this was the Affymetrix. We found this with Affymetrix array, and then we did qPCR to confirm it, and we did a lot of studies to show that it's induced by fasting, not just ketogenic diet. It's physiologically regulated. And then this is a paper that came out around the same time that we were working on FGF21 from Lilly, showing that FGF21 given to mice with diet-induced obesity in a dose-dependent manner decreased their weight, and actually also showed improvement in blood sugars. And the interesting thing about this study is there was no change in food intake. So you had to ask the question of, what happened? And what happened was when you give FGF21 to rodents, you actually get a nice increase in energy expenditure. So this led to a lot of drug companies working on trying to see if FGF21 could be a good new drug, and labs, including mine, trying to figure out what was FGF21 doing in humans. So we thought, hey, if it goes up with ketogenic diet, maybe in mice, maybe we could do it in humans. And we're very disappointed to find that there was no increase after 12 days of a ketogenic diet, and a very small increase after ketogenic diet followed by a fast. We're talking like 10 to 20-fold increases in the mice, virtually nothing in humans. So we thought, okay, maybe we're not fasting them long enough. So we actually got college students who volunteered to be in the CRC on a protocol where we could fast them for 72 hours. There was no increase in FGF21. And then what we found, this was working with one of my colleagues, is that we actually got a robust increase with fructose. So this is a fructose tolerance test showing a 4-fold increase in FGF21 in response to a fructose load. And this is in individuals with a metabolic syndrome. And you'll note that the important thing is this is a different scale, because individuals with metabolic syndrome have higher levels of FGF21, but still have a robust increase in response to fructose. This is a study, I won't go into the details. We also found that in humans, ethanol causes a huge induction of FGF21. So this is binge drinking, was done by a colleague in Pennsylvania. And then he happened to have the samples, and I don't even remember why we decided to look at FGF21 in his human samples after a binge drinking episode, but we found even greater response in terms of circulating FGF21 in humans following this binge drinking episode. We also found, and then around the same time that we reported this, other groups reported it, that the increase in FGF21 was actually a marker of fatty liver disease. It's made in the liver. Individuals who are obese have more FGF21 in their serum. And then as a marker of NAFLD, if you segregate out these individuals, it's even higher and it's more consistent. And we actually got some human liver samples and showed that it's markedly increased in NAFL. It goes down with NASH. We're not quite sure why it does that. And then we put mice on a diet that gives them fatty liver and fibrosis. And this is FGF21 in the liver, actually in the serum of the mice that are eating this diet. There's this huge induction of FGF21 in their livers and in their serum. And FGF21 treatment, okay, so this is the liver of a mouse that's on this diet, which has fibrosis, it has huge fatty liver, and it has, you can see the lipid droplets. And then we gave them FGF21 and they resolved their fatty liver and they had substantially less fibrosis. So FGF21 is an important regulator of systemic metabolism. We don't really understand everything it's doing. I mean, I've got a couple of things that related to fructose if somebody wanted to talk about, which I'm not going to show. But it seems to be important in the liver to maintain fatty acid oxidation. It's anti-inflammatory in the liver, and it's probably very important for carbohydrate disposal in the liver in both mice and humans. Although in humans, it has nothing to do with the ketogenic diet. So multiple pharma companies are pursuing FGF21 for metabolic disease. Most notably and most advanced is Bristol Myers Squibb, which has a pegylated FGF21 with a longer half-life, which is now in phase 3 human trials. and it's great for the improvement of NAFLD, but there is no weight loss. Okay, so this is to show you that something that you think is going to be a weight loss drug may in fact be a NAFLD drug. Now, non-alcoholic fatty liver disease is actually one of the comorbidities of obesity. So indirectly, you're treating a comorbidity. And then obesity is a chronic disease, and waving the wand of diet and exercise is just not going to do it. And then what I learned over this saga that started with those crazy ketogenic diets is that drug development is really hard, and actually I should also include physiologic understanding is really hard, and it's not always linear. This is my lab group before I moved to Novartis. Actually, up here in New Hampshire, we had a day in New Hampshire, and these are the people that I actually worked with over time. These were my collaborators. I love my collaborators. When I didn't know what a liver with non-alcoholic liver with fatty liver looked like, I went to Ahmad Nasser, who's a pathologist, who spent hours with me showing me like liver pathology, which was great. And then I actually collaborated with my husband, Jeffrey, when he became dean in 2007, we joined our labs and, had a good time collaborating. And this is the island my parents are from. They're from this island in the Ionian Sea. They live, you take this road to the top of the mountain to the other side, and that's where they grew up and came to the US a couple years before I was born. So I don't know if I left any time for questions. I guess a couple minutes. Thank you.
So thank you so much. So it doesn't look like we have any questions in the chat yet, but feel free to type them or just unmute yourselves and ask away.
I'm interested, sorry, you got all these people who do diabetes and obesity, but they're not jumping in. So I'm interested in organized programs like weight management programs and things like that. I've watched this field, behind you, as you know, with where it evolved from where people didn't even believe it was, it was part of medicine to it now being part of medicine. And I'm thinking about conventional programs where like there's a medical piece and a surgical piece. And I know you have a couple of them in Boston, but are you seeing, in Sinai, we're still pretty ad hoc. And I'm wondering, what's going on?
Yeah, the programs are great. Okay, I think that the programmatic approach is really important. And the best one in Boston is at the MGH. The BI is primitive in comparison. The approach is that some people do lose weight with diet and exercise. If they're in a program. So I think you really do need to start with that. And I think you need to gradually kind of bring individuals along that they do need more treatment than that. And I think it's really unusual for people to jump to bariatric surgery. Occasionally seen, but usually people say, no, I can do it on my own. I know I can do it on my own. So I think the programmatic approach is great. Lee Kaplan runs the program at MGH, and Fatima Cody Stafford is actually one of the clinicians who sees a lot of patients with obesity. And I think it's, if you could do it at Sinai, it would be a good idea because, first of all, you would make surgeons happy, right? I think also NYU has the programmatic approach. And I think most people respond rationally. You can't have somebody come in and say, you should have bariatric surgery, as opposed to saying, why don't we give you Saxenda and, see how you do. And then maybe it'll work, right? Maybe the combination of behavioral changes, dietary changes, and Saxenda will work. So I think they're great. I think it's the Direct study out of Scotland, which actually looked at intensive behavioral therapy in individuals in a clinical setting, and they got fabulous weight loss. Now you have to look at their protocol. They got fabulous weight loss at a year, but by year 2, people are already relapsing. So I think that just the diet program is probably a dead end. You have to have, what are you doing after the diet?
So I'm going to jump in, Terry, without putting anything in the chat box because that takes time. I want to thank you very much for this talk, which was very clinically oriented, clinical, but also academically oriented for our fellows and for us, for all of us, which is so beautiful to have in Mona Shimshi's memory. And so I think that the fellows, as always, are very smart, and they picked the right speaker for the right occasion. Also, I get a little nostalgic on this day because of my relationship with Mona Shimshi, and a lot of your talk is just like sort of ghosts of Sinai past. So you mentioned John Eng, and who discovered the GLP-1, and
Right.
John Eng did that at the Bronx VA. He was working with Rosalind Yallo at the time, and so that's a Sinai connection. Then I also saw flying across the screen, one of your collaborators was Sarah Flier, who I believe is your daughter, who I believe went to Mount Sinai, who I knew when she was a student here.
Yeah, she did.
Yeah, and then finally, it's going to lead to a little question. You mentioned the OB gene, and you mentioned Jeff Friedman, who is, as we always tease him, the more famous brother of Scott Friedman, who is the head of liver here and a very renowned scientist who works on fatty liver disease, who works on alcoholic fatty liver disease. So the question is, are they using FGF21? Maybe you said it in clinical trials?
Yeah, they are. Yes. So if anybody wants to hear the whole FGF21 story, invite me down for like a research seminar. I could talk, I didn't want to make it all about FGF21 just because I thought, A, it's not available as a therapeutic yet, and B, it was going to be a mixed audience. So I thought So yes. So Bristol Myers Squibb I'm pretty sure is in a phase 3 program. They've already published on their pegylated FGF21, and they are using it in liver disease. So they're actually trying to target the early flip of NASH. So non-alcoholic fatty liver will progress to non-alcoholic steatohepatitis, which has a strong inflammatory component, and that's kind of when the fibrosis starts. So the idea is, can you take these individuals that have relatively early fibrosis and inflammation, and by decreasing the fat load in the liver, actually get them to reverse and go get to a normal liver? And the best data right now is from Bristol Myers Squibb. So Novartis has an asset that they decided to actually sell. So Boston Pharma has our asset, which is a long-acting, what used to be the Novartis asset, a long-acting FGF21, which also appears to reduce fatty liver. And then Lilly had one that they gave up on because they wanted it as an obesity treatment, and you just don't get weight loss. The weight loss is absolutely minimal, and the improved glucose control, it's there, but it's also pretty minimal. So it's really the target is fatty liver. I couldn't talk about the Novartis asset. I would have loved to have talked about it, but it's not public yet. Hopefully in the next six to 8 months it will be. But the BMS data, Bristol Myers Squibb data, is actually fabulous. Whether or not it's going to make it to the threshold, I don't know, but it seems to be safe in humans, and it seems to be effective.
It's great. Thank you.
Great.
Dr. Maratos?
Yeah, go ahead.
Hi, this is Effie Thomas, one of the former Sinai fellows. So I practice in Long Island, and I have I have a specific patient that when they come into my office, I just know it's going to be a difficult patient to treat. So these patients generally look like they have metabolic syndrome. So they have severe central adiposity and usually like thin extremities, and they're mostly female. And they have just severe insulin resistance, and they're complaining to me about weight gain. And all I'm doing is adding to their weight gain by increasing the amount of insulin I'm giving them. And I've gone as far as, looking at leptin levels, because a lot of these patients look like they have some sort of partial lipodystrophy. And I have noted that some of them do have low leptin levels, although that's not the end all be all of the diagnosis. And I've gone as far as referring them to the NIH for studies with leptin analogs. Can you comment on the use of leptin in obesity?
Oh yeah, no, that's actually a great question. There's Metroleptin, right, which is actually prescribed for individuals that have some degree of lipoatrophy, which could be complete lipoatrophy or partial lipoatrophy. And one of the things about those individuals is they have really bad fatty liver disease. If something's gonna, in fact, that's probably potentially the worst comorbidity they have, because that fatty liver disease will predispose them eventually to liver failure. So leptin is definitely useful in that population. Now, there were a lot of studies when leptin came out on, giving leptin to the conventional obese person, right? So somebody who doesn't have a defined genetic cause for their obesity. And those individuals have high leptin. So there's the concept of leptin resistance, that the more obese you are, the higher your leptin levels will be. And actually, Andy Greenberg at Tufts did these studies where they gave extra leptin, and they did not get any weight loss, even at high levels of leptin. However, there was a paper published, I'm pretty sure it's published because I saw it as an abstract, and I think I've seen it as a paper, by Alex DePaoli, and I think Steve O'Reilly may also be on it, that when you look at leptin levels, okay, there are individuals without defined lipoatrophy that have low leptin levels, and those people may be good candidates for a leptin analog, which I think is Metroleptin, is the one that's available. So in an obese state with low leptin levels, there is data to suggest that those people will respond with weight loss. So, okay. And Metroleptin is available. I forget which company actually makes it, but it is available as a prescription. I mean, the other thing to do is to try a GLP-1 receptor agonist.
Yes.
Yeah. Have you tried that?
So I have in some of those people. So, I'm thinking of one in particular who has a very low leptin level, but she's also had pancreatitis due to high triglycerides in the past. So that has limited my ability to use a GLP-1 for her.
Yeah, how many pancreatises have we seen with GLP-1 receptor agonists?
Maybe just one.
Yeah, I mean, seriously, like when I go to I haven't seen one, my colleagues haven't seen one. I think it happens, but you almost have to ask the question, is it really the GLP-1 receptor agonist, or is it the fact that they had some comorbidity that led to that? I agree. It's kind of, you'd have to be really cautious, but she also sounds like she's kind of in a desperate state.
Right. Okay. Thank you for your input. I appreciate it.